I'm Corey Smith. I'm one of the co-leads of the Community for Global Health Equity, and we're going to keep introduction short, and Jared can add to this. We have obviously a series of events over the course of the coming weeks across the whole semester, and not exactly planned, but it's turned out we have quite a humanities lineup throughout the spring semester, so we're incredibly excited about that and what that offers the community. And with that, we have Jared Allstott, who is in the Department of Geography. So go ahead, Jared, you're on.
Thanks. Yeah, so good morning. Thanks for coming out. And so this will not be at all about humanities, but the title, again, Geographies of Inequity, it's not quite what I think would be useful today. So I'm going to talk about how geography can be useful for understanding inequity, how geography might be useful for combating inequities, finding context appropriate solutions for inequalities. And yeah, so I've got about 15 minutes, and I'm going to talk about a little bit about some of the work I do in the first couple slides, and then maybe more broadly what things that geography has to offer that might bring people together across disciplines and be useful in that way. So typical geography, I'm going to start with a map. I picked this map for a couple reasons. It's a little bit dated at this point. It's from 2008. It's produced by the CDC. I used to have, should say down there, but it says at the top now. So yeah, CDC's World Distribution of Dengue Risk Map from 2008. I chose this because I do a lot of research on dengue. I do research primarily in Thailand. I've also worked with some groups in Peru and places like that. Dengue is also kind of in the news because of its close relative Zika, which you may have heard about recently. So I started with this map because it's kind of, it's how geographers think about things. It's the map. And I also started with this because it has some interesting things to talk about. I mean, the cartographers for social justice would have a lot of problems with this map, and we won't really talk about that, but there's some interesting evidence of inequity in this map. Particularly the one I'll talk about is right here on the US-Mexico border, right? The dengue risk area goes to the border, but not north of it, right? And that's kind of strange, right? The pathogen doesn't recognize the border. The mosquitoes, the vector that carries the disease between people, doesn't recognize the border. But, so you might think it's an artifact of the map, right? And maybe it's just sort of, it was a convenient line and a place to end the risk. But in reality, that line does exist. And dengue risk, as you cross that border, is quite a bit different on one side or the other. So when we think of maps, and especially maps like disease risk, it's really, it's not a map in the traditional sense of where things are, but it's a model. And in health geographers in particular, we talk a lot about human ecology. Excuse me, I have a little bit of a runny nose this morning. And when we talk about ecology, it's basically putting together the natural environment, the social environment, the built environment, and in geography in particular, adding in sort of the medical environment or the way that we collect data about something like dengue. So each of these pictures illustrates a part of that. In the upper left here, I have another map from the CDC that shows the approximate distribution of the primary vector for dengue Aedes aegypti in the United States. And so we can see that the vector does not sort of stop at the border. We have lots of Aedes aegypti in the US. Hawaii is not on the map. They currently have a dengue outbreak that's sort of smoldering on. So the mosquito is that's not the reason why the risk sort of stops at the border. But that's an important part of what geographers think about, that interaction between it. It has a long history in the field of what's called the man-land interaction, in the maybe in the 1950s. But thinking about human-environment interactions more generally. On the right-hand side, we have a picture that encapsulates a lot of the difference. This is a picture of the U.S.-Mexico border, the border wall. And this captures a bunch of different things. One, it captures sort of the difference in the way the cities are laid out and planned, right? On the right-hand side, we have, in this case, we're looking east. This is Tijuana, Mexico, on the right side. We have a city that's sort of, it has a center that's traditional old town that's sort of well planned, but a lot of Tijuana is sprawling. It's haphazard development. It doesn't have the sanitation that we might expect in the city, and the cities that are just across on the northern side of the border there. So there's built environment issues, and that includes, again, both sanitation is important for dengue, how people are storing water. The housing quality is very important. So, the mosquito is on both sides of the border, but the opportunities for interaction are much more plentiful on the right-hand side than on the left-hand side. And that has to do with things like air conditioning, right? And on the U.S. side, houses are much more likely to be air conditioned and tightly sealed. On the Mexico side, they're much more likely to be, loosely sealed, maybe even without screens at all in some cases. So that's another part of this map, or the model behind this map that we saw at the beginning. And then this last thing I put down here on the bottom is it's actually the virology research unit in the area where I do work in Thailand. But our ability to detect dengue and to properly diagnose dengue varies widely globally. So that's another very important part of this map, sort of the sensor that we're using to actually capture the disease of interest. And so even in a place like Thailand, where dengue it's a disease of children, it's a major cause of hospitalization among children, so it's a big public health problem, but the ability to properly diagnose and serologically confirm dengue varies widely from place to place, even within a province or within a district, and things like that. So all these things sort of come together in a map. So it might seem relatively simple, but it's actually can be a pretty complex and sometimes sort of a sausage factory kind of thing that goes on before we get to that map. And it shows also that geography, I'll come back to this, but geography has been, especially medical geography, kind of an interdisciplinary field and an integrated field from the beginning. Any questions? All right. So what I thought I would do next then is talk about some of the ways, and I've called these geospatial technology, but I'll just talk about some things that we do, not only me specifically, but people in geography do that can be useful for understanding inequity and sort of designing solutions. This first picture here is to remind me, I think people are getting pretty used to seeing things like this. This is what we would call a remote sensing image. We're used to Google Maps and so forth, being able to click on the satellite button and see sort of the picture from space or picture from airplanes of a place, and that's a really useful thing, right? Especially in places where we can't go and be on the ground and easily sample places. But remote sensing is a lot more than that, and so that's what this image reminds me of. So this is a remote sensing image from a health application. It was about Rift Valley fever, so another vector-borne disease in Yemen. And the red here represents places that are irrigated, so places where there's water, and the green it's kind of counterintuitive. The green represents places that were dry. So this is sort of a part of a Rift Valley risk map, or a Rift Valley response, rapid response, and this was developed by NASA. So we can use also remote sensing not just to find things where they are, but also to actually map things that you can't see easily from, with the eye, or that you can't measure it very easily. So it could be something like this, like moisture, or where there's irrigation, but it could be vegetation types. More and more remote sensing is now being used in urban environments to understand population densities, housing quality, socioeconomics, indicators of socioeconomics, and so that it can be used where we're sort of data poor environments to develop relatively accurate and with high spatial resolution about what is on the ground. One other geospatial technology that you may or may not know about is sort of radar-based technology, which is used a lot in disaster response, and that's just tells us about, it's a way to develop a very quick 3D model of the Earth. So after hurricanes, or 9/11 is probably the most cited instance of this, where remote sensing applications were used to show sort of on the ground, even when you couldn't see through the smoke, of 9/11, how the environment had changed and how response activities should be carried out. And I've used that kind of, it's called LiDAR, it's a kind of like a radar technology to map houses in places where there aren't good census data, so we really don't know. So if we're doing sampling and you don't know, there's not good census data, but you will need to find the people and find different kinds of environments, remote sensing is one way one technology that can be used to do that. So I'm summing up all these sort of, these sort of big fields. These are fields in themselves, but things that we do in the department here at UB or in geography more generally might be useful. So that, we could talk about each of these things for a long time, giving you a flavor. The second one, I think there's probably people in here are pretty familiar with this kind of technology. This is these lines on this map are actually all the movement of a person for a 1-year period. It's zoomed in on it. He did go some places that are a little bit off this map, but this is his main neighborhood and many of the places he's gone. This is using the GPS or satellite technology to understand where he's been for a year. And these kinds of maps can tell us a lot about people's behavior. It can tell us a lot about people's exposure. Some of my colleagues have used these kinds of things in combination with sensors, like air quality sensors, to understand a person's exposure to pollutants. In the research I'm doing, you can also use cell phones to do this. You don't necessarily need to use the satellite technology. And Wi-Fi, there's a group at UB who is using the Wi-Fi network to understand people's movement within buildings and people's interaction within buildings. So that's, so this is sort of generally to how we understand people's movement, or how we can measure people's movement to understand their interactions and exposures. We're using a technology in Thailand in our study called Moats, but it's a little bit simpler. It's Bluetooth based, and it just tells people just carry the sensor, and it doesn't tell us where they are, but it tells us how long they've been together. So it tells us proximity to, and you can put those in stationary locations, and so that we can tell how long people spend in their house and who comes in, and how much time they spend together, things like that. So that's another technology that might be useful in that way.
This is really cool because you can see how habitual this person's behavior is.
Right. Yeah, and it's very cyclical too. I mean, you can dissect this, but at certain times of the day, in one spot and another and so forth. So that's another one. This is another, I mean, this is something that all fields are kind of grappling. It's sort of geography's part of the big data issue, or, you know, it's, I guess, well, there's many geographers working on many different parts of big data, but something we call volunteer geographic information, a phrase coined I think in 2006 or 2007, is sort of where geographers have been, you know, sort of making contributions and doing things like that. And this is just simply, I mean, we might think about it more simply as social media data with a geolocation, you know, so people are broadcasting a lot of their information out into space, and they oftentimes they're hashtagging with their symptoms even, or with their diagnoses and things like that. So so people are using that to augment what we might call trusted data sources or traditional data sources to understand different different phenomena. Here's an example, and you may have heard about this. It's sort of a interesting case study in this. It's called Google. It still exists. Google Flu Trends, and this was based on Google searches for terms related to flu. And there was also Google Dengue Trends too. So I think those were the only two diseases that they ever put sort of out there as sort of, and they call it nowcasting. So it's real time. I mean, that's another big advantage over most of the traditional data sources, that there's really no delay. You know, it's almost instantaneous that you can understand the timing and the spatial patterns of these things. If you know more about Google Flu Trends, if you go to Google Flu Trends now, you get sort of this page like, sorry, it didn't work, and we don't do it anymore. We don't at least show the public the results anymore, because at least the initial iteration of it stopped working very well. But I mean, you know, and there was a lot of sort of gloating and, you know, articles in Science about how big data is not the answer. I mean, I think most people never thought it was the complete answer anyways, and, you know, it can still really be useful for augmenting traditional data sources, right? And so I have a colleague, Monica Stevens, who does sort of a lot of Twitter-based analysis, including, and she's done she has a paper in submission about diabetes in Twitter, and tweets about just tweets about people's programs, you know, their diet and things like that, and how they tweet about those things and managing their diabetes.
Wait, can I say one thing about this? When I have seen these, I've often worried that the medically underserved are likely also the digitally underserved, and that this is likely to be less representative of those individuals who are at greatest risk, or at risk of being really cared for.
Oh yeah, I completely agree. And so a lot of the research, Monica in particular, looks at gender bias and these kinds of things, but, you know, there's other people that are looking at these social biases. I guess the flip side to that, though, is that if people have something, they often have a phone. And so they do, you know, actually it's, in some places, they're probably much more likely to participate in, and, you know, maybe somehow broadcast their symptoms than they would be to get to a treatment center. So yeah, no, I agree completely. It's you know, and I mean, the fact that Google Flu Trends sort of stopped working sort of shows that it's something that it needs kind of constant care. It's not something it's not something that can work in 2016 and keep working in 2017 because people just change so quickly on how they use these technologies.
We did a quick check with our Head Start programs here to see we have that same concern, and 90% of them will
Yeah.
I mean, I just wonder what they're using those forms for, and,
A
but,
lot of them say they'll pay it before rent. The connection is a higher value. So interesting.
Yeah, and also, I mean, if you're tied to things like public transportation and things like that, the smartphone becomes even more smart because you have the schedules and things like that. You don't have the autonomy of a personal transportation. Yeah, there's a. It's okay, and I think I just have a couple more. But this last slide here in terms of technology, I've just put it up here to symbolize a bunch of things. One, it reminds me to talk about something that's kind of old hat now, but can be still very useful, and that's geographic information systems. So just the computer technology to put all this stuff together. To just, I talked about human ecology. So to put data sets about the built environment, about the natural environment, about where people live and how people get around. To put all that together, we have the computer technology, geographic information systems, and that's long been a strength. The UB Geography Department's National Center for Geographic Information and Analysis. And so it's one to remind me about the computer technology, and another to remind me to talk about how, geographers have been, because we've been sort of this, it's kind of a shortcoming of the field, but also a strength of the field, because we've kind of always been integrated. The techniques we use, whether it's statistical or whether it's qualitative, they often go across these kinds of boundaries, disciplinary, different kinds of data types, natural, social, cultural, built environment kinds of things. We put them together. And I guess one example, and here's a chance to talk about my colleague Inky Yu, who does the kinds of statistics, or she concentrates on her research concentrates on the kind of statistics that put these things together. It's not a simple matter to take things that are measured at very different scales, measured at very different time intervals, and put them together in a valid statistical manner. And so that's another thing that we worked on. And so the last thing, so I often pick images for slides because they make me chuckle a little bit at first glance, but so this slide is kind of one of those, because there's an attempt, it's in Moon Damit and Mike Epsch's medical geography textbook from 2010, and there's all these attempts to kind of summarize what geographers do in one picture, right? And this is one of them, but it brings me back to the final point that what we often are trying to do is whatever the field maybe that the phenomenon traditionally falls in under study, whatever the spatial scale, if we're thinking about individuals, if we're thinking about neighborhoods, if we're thinking about counties or whatever, and also things measured through time, and how stuff changes spatially through time. It's kind of what we do, putting things together. And I think so. Hopefully that if you as we make these connections in the community for global health equity, you can make these connections hopefully across fields and across disciplines. But maybe if you're looking for sort of the glue that holds that together, whether it's a technology or a way of analyzing things or a way of visualizing and summarizing things, you can think about geographers and how we might help with that. So, yeah, I hope that helped.
I think the point of this was to help a diverse set of people to have just the slightest inkling of vocabulary and the ways in which, our scholars scholars around various disciplines are conceptualizing the issues that contribute to inequity, and as you talked about, solutions to inequity as well. So this was a really nice kickoff to that. I think I've seen Corey all session writing profusely on bright green Post-its as this has worked. So you were gonna take it away for some discussion.
Yeah, we're just gonna open it up to the group. I may or may not share sticky notes. That's okay. I may or may not draw, and somebody else may or may not draw. But so with that, we'll open it up to conversation, and all I would ask each person to do is just quickly introduce yourself, your name, and whether you're a student or a faculty member or staff member, and what discipline you come from as well, please. Jared.
I'm John Kempton from microbiology and immunology. So Jared, it's interesting we've been talking about some of these different things. So Jared and I are co-leads for the infectious disease working group, and we've talked about this drug access project. So, it's really cool to see how everything can come together and how the data can be analyzed. But as somebody who is a wet lab researcher, my question is, if I wanted to know what clinics in Uganda have 5-fluorocytosine and which ones don't, in my office in Buffalo, what's the first step, and what's the path, I guess?
Well, I mean, so there's some rules with geographic information, and one would be, that you're likely to find the best information about that in sort of the footprint of the area you're looking for. So, there may be a Ugandan, I'm sure there's a Ugandan source that would be the best one. So there's some rules like that. They might not apply in this particular situation, but so we have some of those kind of general laws of geographic information science, or sort of tendencies for how that stuff exists and how you can access it. In a more practical sense, it probably is going, there'd be collaborators and people that somebody at the university knows that would have a better idea.
There may be publicly available data sets, right? So the USAID supports these DHS surveys, the demographic and health surveys, which are nationally representative household surveys. But as part of that program, they also support SPAs, which are service provision assessments, which are healthcare facility surveys. They're less frequent. And then also there's an HIV/AIDS survey as part of that, which, maybe where you're looking. Those have, I think, mainly a household component, but there might be a facility. So there might be publicly available data sets, or, Uganda is a PEPFAR country, so PEPFAR, which is the President Bush's President's Emergency Plan for AIDS Relief, there might be some good data out of that program. So I think there might be a number of data sets, but it's the linking of you asking the question and then, the rest of us saying, are there data available already? Or collaborators with whom.
And that was just an example. But,
But
but just in terms of thinking about.
But for you, that's a
the
relevant
process,
question,
right?
right?
What's the process, and how do we facilitate that?
As a community?
Yeah.
Yeah, my point being that there may already be publicly available data sets or connections we can make with colleagues who have that information.
Yeah, you'd be surprised. There's also some kind of strong linkages between certain countries and certain groups, like grad student works in Zambia, and so it's the London School of Hygiene, and does a ton there, and so a lot of the data, so if you can find these linkages in the scientific literature, kind of that often is a big thing as well.
Question?
Yeah.
Levin from Industrial Engineering. I'm one of the faculty lead events like the global health. Kind of related to the question now, from the geospatial type of data, let's say that the World Health Organization would like to use this to predict the outbreak of certain diseases. And how would you link that from this to the diseases? Let's say that malaria, maybe that by detecting the water, amount of water that exists at a certain point, that can directly correlate to the mosquitoes, multiplication. So maybe that's one way. But what other, I don't know if I'm saying the right thing, and if any other diseases that can be related indirectly or directly by the use of this geospatial information.
Yeah, no, I think that's, I think that's kind of what's going on with Zika right now. So taking what we know about Zika, it's sort of natural history in terms of, we know the likely culprits in terms of vectors, and it turns out to be the same one as for dengue. So we know what are the ecological limits to that. The crude limit has always been if the temperature gets below 10 degrees Celsius for longer than just a couple days, that would be too cold for the Aedes aegypti to be there pretty much at least year round. So there are, you could draw that sort of temperature line on the map. Malaria is a case where altitude plays an important role for the Anopheles vectors there. So you're putting together temperature, altitude, and then you have to start going into some things like these socioeconomic things, understanding housing quality, to get to finer scales. I think then you go to, you just bring in sort of the deeper knowledge, the more granular, I guess, or maybe more fine resolution data. So all of this, there's, almost every major infectious disease sort of has these kinds of groups working on them that are creating these global risk maps, and the efforts, what I've seen over the last 10 years is that really the efforts they keep coming down into getting like finer and finer data. We have these broad boundaries for things, and now understanding and groups spend a lot of time getting better and better data to understand the heterogeneity within those broad boundaries.
So regarding the risk maps, what I was wondering is, one of the things that you had identified early in your presentation is the difficulty, particularly in certain geographies, with diagnostics of dengue. And I'm wondering if there's a kind of proxy quality to maybe some of the spatial mapping. So if I can connect that issue with what you were talking about in flu trends, would there be a way of collecting spatial information, probably through multiple tools, the kind of large-scale satellite imagery kinds of tools with remote sensing, where I could help assist with that diagnostic quality? I can't do that maybe at the individual level, but I could spatialize, here are where the vectors or risk factors, particularly in real time, where we might look at that. Is there capacity there? Is there something going on in that regard, specific to dengue or others?
Yeah, I think that's a part of it. So there's places we just know that dengue should, all the conditions are there, but it's never diagnosed, and so there's a rapid, WHO has a rapid dengue response team, and they find themselves being called to more and more places, because of that knowledge, right? So before, another thing with dengue, I could talk about dengue forever, but lots of dengue is asymptomatic, so people don't experience any symptoms. So there's a lot of silent transmission, and then dengue and Zika are very hard to tell apart a lot of times from anything. From a cold, from a flu. There are some telltale signs of rashes and things like that, but those don't always occur, and so. So there's places where they just get mixed in with everything else, and they just, it's a viral infection, and people are recovering pretty quickly, and so that's, there's no need, in some sense, to have the expensive diagnostic technology or whatever. or to do that. But
But there is to
but-
differentiate with other treatable conditions.
right.
Like typhoid. I mean, there's always a fecal oral component.
But as sort of healthcare systems are becoming, stronger, and that sort of ability and need arises, this WHO rapid response group is getting called out to places that they've sort of, we've always thought it was there, or they've always thought it was there, but it had never really been diagnosed before because of now the ability to, and I guess the resources are there now that it's important to separate and to make the diagnosis, so that kind of answers the question, I guess, or as well as I can.
Jessie, what do you say?
Well, I really liked your slide from Mead and Oach, that matrix. So I'm Jessie Kastner from the School of Nursing, and in nursing, our sort of sacred word is holistic. Like I know Lee's talked about their sacred word is optimization in his discipline, and so that's that nice way that we've always been trained to think is people start with symptoms. They don't access the diagnostics. They don't access the healthcare system, and so I love it that you're getting ahead of that with documenting the symptoms on social media, and how does that spread. And as a co-lead on the non-communicable and chronic disease, my focus is asthma, but what actually exacerbates asthma is infectious disease trends. You get the flu, you get the cold, and then you exacerbate that chronic disease. So it's all connected anyways. But a lot of the studies on time activity patterns, looking at behavior, right now in my study, this actually gathers GPS data. It's a simple, a lot of the Fitbit and stuff, you can stamp and look at these patterns, and that does seem to really tell when a chronic disease exacerbates and where we're going. So all the way, from the gene-environment interactions to policy and who's accessing the ER, has that geographic component. So it was an interesting model to sort of see from the cellular level all the way to the population level. And with my interest with respiratory, that really does define a health inequity. And I thought it was a very interesting paper, so thank you.
So that was the diagram that
The
Jared
matrix, yeah.
showed, right, and it had time in this direction, and then it had, I think, scale was it was missing that scale. One of the scales that is being talked about, which is the micro scale. It stopped at the individual.
Right.
And so that's
Go
one
all
of
the way
the
down to-
challenges we've been facing, is how to link that then across all of those other scales, and then with all of the subject matter that's listed there.
And even go down from the cell to the gene.
Yeah.
I agree. I mean, for me, the macro applications, global, transnational, and so on, are pretty readily apparent. But when you have mentioned Moats to me before, that's been really exciting, kind of looking at the micro environment of an individual. I wondered if you could talk about other applications that you've seen of Moats in the literature, or ways in which you think it could be useful to use that to map risk, or to
Right.
kind of explain behaviors or otherwise.
Yeah, that's a good question. So, I mean, I honestly haven't seen too much published work using the Moats, except there's that, I think I mentioned to you, that big study of Pittsburgh area school kids understanding social networks in I believe a high school to inform individual level models of flu transmission in that social environment. One reason the Moats are advantageous over maybe GPS is because GPS signals are, you go indoors and they're problematic indoors. The data is it's just so much data. So Moats are easy to narrow down to just where people are, where who's together, I guess, and it's actually pretty tricky to feel confident or to have certainty about that with GPS. So it has many sort of data advantages there, and that it's actually smaller data but more digestible and dependable in some sense for those studies. But when I was thinking about your work, you know, and you mentioned it right away, is like a hand washing station, right? You put one on a hand washing station, you put them on people, you can validate what are they saying versus what are they doing, right? Very, you know, and it's pretty non-invasive too. They're small, they're not, and I think people kind of would be more likely to forget about them too than if they know they're carrying something that, you know, will say where they are all the time. You know, it's-
You know, it's RFID in hospitals.
Well, right, I mean, so how are moats different? That's what I was gonna ask about.
It's the same technology,
It is
I
the same.
believe, yeah. Yeah, it's just that it's a small thing that you carry around.
Can you explain what that is?
RFID.
RFID.
So on my Nexus pass to get into Canada, it's ingrained in the card.
And in hospitals, a lot of times they can actually add it to, I think it's a radio frequency signal, but they'll add it right onto your card.
Onto the staff.
So it's very unobtrusive. And then you can track. The problem was they had to negotiate because the staff didn't want them to know how long they were in the bathroom or when they were on break. So there is this sort of big sister aspect to, yes, you have good intentions, but I don't want you to know about that.
Right.
So, yeah.
Well, here's an application I'll just throw out. So we see in you know, I've done work on hand hygiene in the newborn period in Bangladesh, and we do observations of the household where we have an observer sitting in the home and observing. So the likelihood that people change behavior in the presence of an observer is high. But separate from that is that we find very few events of fathers and grandfathers coming into contact with the newborn, which has its own implications for bonding and development of the newborn in different ways, right? So a Moat application, in order to look at interaction between newborn and different members of the household, could be a useful way to understand how much time do fathers actually spend with their newborns and young babies as part of a child development process. I mean, it could be a neat way to look at that. Because, you know, one of our challenges is we're doing this work during working hours, when indeed the males of the household might be away. But I suspect it's a lot more than that, and that there is genuinely relatively little interaction. Shazanaka, who's from West Bengal, is agreeing with me.
So I'd like to ask a question and get you all to participate. It won't take very long. You have two Post-it notes with you. This is something that's actually come up with several conversations, not just today, is about both the strengths of any individual discipline in terms of its methods and approaches and ways of thinking, as well as the major barriers you're often confronted with in terms of data collection or advancing that field forward. So what I'd simply like you to do is, on the yellow note, so Jared shared with us what geography is about, what it's equipped to do, and how it can contribute to global health equity in that conversation. So what I would ask you to do is, on the yellow note, if you would simply write down, and we have lots of big fat markers that would be preferable to get those out, what your discipline or your approach, methods, what the discipline effectively is and does, how it operates from a methods standpoint. And then on the orange note, what are the major challenges that you're confronted with in your research in terms of methods or approaches, data collection?
So the yellow is for
Yellow.
your own discipline.
Yellow is for your own discipline, what it does, what it offers, and orange are basically the challenges you're confronted with in terms of data collection. The limitations of the field methodologically. while people are writing, I do have another question. One of the things that I wrote down first was the cartography of social justice. I've not heard that phrase before. That's a good one.
It's a joke.
Oh,
It's actually, it
I
comes
took it
from,
very seriously.
it comes from the West Wing, the show.
Oh, okay.
There's a, if you Google cartographers for social justice, the clip will come up. But it's about, they want the government to change the projections that they use for maps, because it's not a new problem, I think. But that map I showed, it has, the Americas are like at a very different scale than the rest of the world.
Right. But map making has always had a quality of authorship that communicates the worldview of the author.
Oh, yeah, definitely. And the Mercator projection that we all see is, I mean, it was made across the oceans. And I mean, nobody, Mercator never intended for it to be the map we look at on classroom walls.
But there it is.
Yeah.
We can start a
We
new
like-
movement to
We
get
like
new maps in
rectangles,
classrooms.
right angles and rectangles.
Yeah.
Did they do it in a walk and talk in West Point?
No, they had a presentation for, it was like a short PowerPoint.
With the orange.
The orange are the limits that you're often confronted with in terms of the work that you do. Data that's difficult to collect, progress that's difficult to make in terms of finding solutions. So I'll try to move through this quickly so that if there's a last question, we can get to that and everybody still has time to go about the rest of their day. So what I would actually like to start with is one of the orange Post-it notes. So what are some of those challenges that you're confronted with? Somebody share one? John?
Sure. Well, I guess I wrote down beyond the bug, right? In microbiology, we think about our pathogen and what makes it tick and what makes it be a pathogen. But it's hard, as in the example that I mentioned, to think outside of the walls of our lab and really look at the bug from this perspective of global health and especially equity for diseases that are infections that are most common in under-resourced areas.
So I'm going to try this. If it doesn't work, we'll switch approaches with collecting Post-it notes. Does somebody have on a yellow note something that would contribute to addressing that particular issue? So microbiology beyond the bug. Yeah, what is it?
I have a couple.
Yeah, good.
One is nursing is informed by very holistic and collaborative approaches.
So the complement to the beyond the bug is the holistic mode of operating and thinking. Okay, somebody else, another orange one, please. That one worked. Let's see if we can try it again.
Well, here I'm speaking for history. I could also have spoken for medical humanities, which are not quite the same. But the challenges are, I think, in part for us, the gaps that exist in sources. So they're different, the availability of different sources for different times, different places, and it's unequally distributed. Plus, access to them is different. The adequacy of the sources for any given set of questions may be rich for certain socioeconomic kinds of data, but not for individuals or vice versa. And then there's also the problem of how to compare sources and data over time and across societies, countries, and the like.
Okay. So missing sources, missing information, really rich information in one area for one population, very lacking. Somebody have a complement to that might address it. Lee.
Well, I have to talk about this yellow sheet for a moment before I get to this.
Okay, that's okay.
Industrial engineers do things to, it doesn't matter what domain, we do things to improve the quality and reduce the cost and improve efficiency of any business and make it better safety. And so what we are strong is that modeling and analysis just about any systems. And my colleagues and myself work in just about any industry, in the military and the higher education, K through 12 and public sectors, any place that we can find our application. So our challenge on the orange sheet is that data availability and dealing with incomplete, inaccurate, and even the incorrect data. And I work a lot in the hospitals, and they always tell us that we have tons of data. That's very true. But once we get the data, and in order to trim it down and to the actual meat and cut the fat out of that, it would take tremendous amount of time. And so this is our kind of a challenge. If we have the data, the right data in the right consistent resolution across the different parts of the operation, and we can model it and analyze it and develop solutions.
How do you deal with the uncertainty of that missing
Probabilistic, and we have colleagues who work on probabilistic models, and that can represent the uncertainty.
Anybody else? Particularly relative to that question, how do you deal with missing information or inaccurate information?
Well, I know I'm not going to speak for my own discipline, but in bioinformatics, they're developing some pretty incredible methods to deal with exactly what Lee's struggling with, whether it's natural language processing or some sort of novel ways to look at that problem.
Somebody else, let's take one more orange one. Let's take one more challenge.
I just put in,
You just introduce yourself.
sorry, I'm Shitaraka from the Department of Rehab Science. It's mostly involving planning interventions for individuals with disabilities, could be mental, physical disabilities. Now, I think we discussed a little bit about dissemination of data, and I'll take it in terms of dissemination of an intervention plan and how it moves from person to person to person, but how to keep a track of it and how to know who's just listening to it and who is listening and using it. How does that flow? I think there is answer out there, but I don't think I am knowledge able to figure that out.
So you're talking about the full loop. We get information from that, we disseminate information, we develop practices or protocols or ways of working, solutions, and then the
Yes.
follow through on that and being
Yes,
able
but-
to assess the effectiveness of whatever we're doing.
True, but as a therapist, if I am responsible for disseminating, I can keep a track of, okay, this is the individual. But when it flows from person to person to
Person to
person, and
person.
I'm not the main center, then how does that?
Anybody have, from your particular disciplinary background, a way of addressing that particular challenge? Your discipline is particularly well equipped at doing that. Something you're confronted with. Anybody in the public health world?
Corey, I would actually add that, infectious disease has that same issue of, we call it compliance, right? So mandated administration of tuberculosis medicines, trying to keep HIV patients taking their 150,000 pills a day so that they don't get opportunistic infections. Like those infectious disease compliance issues, I think, are sort of similar. It's like unless you watch a patient take a pill, you can't know that they're taking the code.
Well, this is where I think medical humanities does come in on that level of physician and patient, one sort of interaction, because, compliance is an issue that comes up, of course, in medicine over and over again. But I think sometimes it's a misnomer because it assumes that the problem is on the part of the patient. But often it really has to do with the dynamics of interaction, understanding, miscommunication, when jargon is used and it's not used, and failure to understand the circumstances of the patient and how to translate interventions that we know can be effective into effective interventions, that is, into interventions that actually have a possibility of altering behaviors, and that's a very complicated issue.
So I'll encourage everyone to do a little bit of mingling, and as well, I'm going to leave some notes up here. We've outlined these. We always welcome you all to categorize your own work at the end. Before that, we'll thank Jared for his presentation.